Sarah Williams, 45, from rural Australia, was diagnosed with relapsing remitting multiple sclerosis in August 2017. She lives in a double-story home with her husband and three children and works as a high school teacher. Flare-ups, fatigue, and prolonged standing have made managing her workload challenging. Previously meeting physical activity guidelines, she now reports low confidence at her local gym and has gained 15 kilograms since diagnosis. During flare-ups, she uses a single-point stick and experiences increased weakness and numbness on her right side. Multiple sclerosis is a neurological condition where the immune system attacks the protective myelin sheath that covers nerve fibers in the central nervous system. This disrupts communication between the brain and the rest of the body and can result in a wide range of symptoms depending on the location of lesions. Relapsing remitting multiple sclerosis is the most common type, with it being observed in 70 to 80% of MS patients. RRMS is characterized by episodes of new or increasing neurological symptoms followed by periods of partial or complete recovery. Common symptoms include bladder and bowel dysfunction, depression, cognitive impairment, fatigue, sexual dysfunction, sleep disturbances, vertigo, and chronic pain. Over time, repeated relapses can contribute to culminate neurological damage and functional decline. To help gain a complete understanding of Sarah's cultural, physical, societal, financial, and personal needs, the International Classification of Functioning, Disability, and Health Framework will be used. When looking at her body functions and structures, Sarah presents with right-sided numbness and weakness, along with increased fatigue. These symptoms affect her neuromuscular function and balance, as reflected in her single leg stance time and lower times in functional mobility tests like the tug or 5 times sit to stand. She experiences considerable fatigue, scoring 40 on the fatigue severity scale, which impacts both her physical capacity and daily function. In regard to activities, Sarah finds stair climbing and prolonged standing particularly difficult, which affects her ability to manage tasks at home and in her role as a high school teacher, as she is beginning to experience flare-ups. Participation is also affected as she has withdrawn from regular gym attendance due to a drop in confidence, and her recent 15-kilogram weight gain has further reduced her willingness to engage in physical or social activities. Fortunately, Sarah has strong environmental supports, including her husband and three children, and access to $6,000 in NDIS funding for her exercise physiology services during her 12-week stay in the area. She lives in a double-story home which possesses additional physical challenges, particularly during flare-ups. As for personal factors, Sarah is highly motivated to improve her physical function and self-confidence, but the psychological burden of fatigue and body image concerns must also be acknowledged. An individualized and supportive exercise intervention can address these barriers and help restore her independence, confidence, and functional capacity. Sarah has expressed her goals are to increase her ability to walk up and down stairs, increase her standing endurance as she currently struggles with that whilst at work teaching, and finally decrease her body weight, which she believes will increase her self-confidence. Some short-term goals for Sarah are to improve her right-sided coordination by improving her step tap test to 16 on her left side. This is important as coordination exercises enhance neuromuscular control and limb coordination, particularly for MS patients with asymmetry. Additionally, a short-term goal is to reduce her 5 times sit to stand from 14 to equal to or less than 12 seconds. A 5 times sit to stand has been shown to be a valid tool for assessing lower limb strength and functional mobility. The final short-term goal is to decrease fatigue severity scale from 40 to less than 35. Aerobic and resistance training is seen to reduce fatigue in people with MS. These short-term goals align with Sarah's goals of increasing stair climbing and increased lower limb strength. Some midterm goals for Sarah are to complete a 10-step ascent and descent circuit with improved symmetry and reduced rests. Stair training helps improve task-specific movements for MS patients. Another midterm goal is to increase 6-minute walk time distance from 385 to 440 plus meters. A 10 to 15% improvement is both realistic and clinically meaningful at this stage of the program. The final midterm goal for Sarah is to increase her right step tap test from 13 to 16 plus in 15 seconds. It has been seen that coordination drills and resistance training improve motor control in individuals with neurological impairments. These midterm goals align with Sarah's goals of increasing stair climbing and increased lower leg strength. Some long-term goals for Sarah are to reduce her timed up and go time from 15.4 to less than 12 seconds. By having an improved functional ability, this will reduce her falls risk. In conjunction with this, confidence in her stair walking and having independence with this. It has been seen that a combination of strength and functional training improves stair climbing ability in people with neurological conditions. Finally, a reduction in body weight from 85 to 80 kilograms. A loss of 0.5 to 1 kilo of body weight over a 12-week span is a realistic and healthy approach. These long-term goals align with Sarah's goals of increasing stair climbing, increased lower limb strength, and a decrease in body weight. Sarah's outcome measures reveal impairments in strength, balance, and cardiovascular function, largely influenced by her RRMS and current health status. Her BMI of 33.2 classifies her as obese, which may contribute to reduced mobility and increased fatigue, though her resting blood pressure and heart rate remain within normal limits, indicating stable cardiovascular function at rest. Balance is notably affected on her right side. In the single leg stance, she had 18 seconds on the right versus 30 on the left, reflecting her reported right side weakness and numbness. The step tap test supports this with 13 taps on the right and 18 on the left, indicating reduced speed and coordination, especially for tasks like stair navigation. Strength and functional mobility are also reduced. Her 5 times sit to stand of 14 seconds is slower than age norms, suggesting lower limb weakness and difficulty with transitional movements. Her timed up and go result of 15.4 exceeds the 13.5-second falls risk threshold, highlighting impaired dynamic mobility. Cardiovascular endurance is diminished with a 6-minute walk test result of 385 meters, below the 5 to 600 meter normative range for her age and sex. This likely reflects deconditioning, fatigue, and low activity levels. Her fatigue severity score of 40 out of 63 indicates moderate to severe fatigue, a common limiting MS symptom. In summary, Sarah has a right-sided deficits in balance and strength, reducing endurance and significant fatigue, factors that compromise mobility, increase falls risk, and affect daily functioning. A tailored program targeting balance, lower limb strength, endurance, and fatigue management is essential to improve her function and quality of life. Some additional assessments that will be implemented are handheld dynamometer testing. These tests will will provide an objective measure of strength to aid in prescription to further address her right-sided weakness. Furthermore, the Borg balance scale will be used. This will use to show static and dynamic balance. This will further aid in identifying falls risk and limitations in activities like stair climbing, turning, and reaching. This is important to test as the results are directly relevant for her goal of stair climbing. Lastly, the modified fatigue impact scale will be used. Whilst the fatigue severity scale has been used, the modified fatigue impact scale is a more comprehensive and better suited test for people with RRMS. As fatigue is one of her main barriers, by understanding physical, cognitive, and psychological impacts, this will help support her and aid in creating a tailored program. Here is Sarah's weekly overview. Monday and Thursday, she will be in the clinic performing her tailored program. Tuesday and Friday, she will be complete her hydrotherapy appointment with the exercise physiologist. On Wednesday, she can either rest or have an active recovery day performing a stretching flow routine. Saturday, she will perform a light walk with her family for safety considerations. Finally, on Sunday, she will rest. Sarah's in-clinic exercise program supports her goals of improving stair walking, standing endurance, and reduced body weight through a combination of aerobic resistance, balance, and neuromotor training. The warm-up includes light mobility exercises like seated marching and shoulder rolls at an RPE of 9 to gradually raise cardiovascular demand, activate neuromuscular pathways, and reduce spasticity risk. The main session targets functional strength and endurance with body weight and machine-based exercises such as sit to stands, wall push-ups, and seated rows at an RPE of 12 to 15. These mimic daily activities and support her independence at home and work. Aerobic training is completed on a recumbent bike at an RPE 11 to 13 to promote cardiovascular health and support weight loss without triggering fatigue. Each exercise has 2 progressions options over the 12-week program, increasing load or complexity. Examples include progressing from a standard to weighted sit to stand, or from tandem walk to eyes closed tandem walking. Balance tasks like single leg stands and a button tapping game target coordination and proprioception, helping reduce falls risk. The session ends with static stretching and controlled breathing to aid recovery, flexibility, and autonomic regulation. The program is adaptable to symptom fluctuations such as fatigue or flare-ups and aligns with Sarah's personal goals and lifestyle. It also utilizes her NDIS funding to deliver progressive, targeted clinical exercise physiology sessions. Sarah's hydrotherapy program complements her land-based sessions and supports her goals of improving stair navigation, standing endurance, and weight loss. Hydrotherapy was chosen for its reduced joint loading, lower fatigue impact, and the buoyancy and resistance benefits of water, which is ideal for managing MS symptoms and reducing the risk of UTOF's phenomenon. The session begins with a gentle warm-up of walking laps and underwater arm/shoulder movements at an RPE of 9 to 11 to boost circulation, reduce stiffness, and prepare for higher intensity work. The main session targets strength, balance, core control, and cardiovascular fitness through exercises like submerged step-ups, single leg balance, and jumping jacks at an RPE of 12 to 14. Each exercise includes graded progressions such as moving from ledge supported to unassisted movements or increasing difficulty in deeper water. Balance and neuromotor control are addressed with tandem stance, trunk rotations, and heel toe walking with eyes closed, targeting falls risk and proprioceptive deficits. Seated flutter kicks and knee lifts build lower limb endurance and core strength, supporting stair climbing and prolonged standing. The cool down includes slow walking and static stretching to aid recovery, flexibility, and muscle relaxation. This hydrotherapy session provides a lower fatigue alternative to land based training and boosts Sarah's confidence in movement by offering a safe, supportive environment. Over time, it will help her build the foundational strength and endurance needed to achieve her goals. Some of the absolute contraindications that should be considered for Sarah is an acute MS relapse or sudden worsening of symptoms, an uncontrolled or recent cardiovascular condition such as unstable angina or a heart attack. Finally, her asthma is uncontrolled. Some of the relative contraindications that should be considered for Sarah is her fatigue levels. If her fatigue levels worsen during or after a session, any MS-related mobility impairment such as weakness on one side or numbness should be considered. Heat sensitivity is common and can exacerbate symptoms such as numbness, her previous right ankle fracture, as this may contribute to weakness on that side. When training clients with multiple sclerosis, clinicians must consider specific safety measures and monitoring strategies. Sarah experiences right-sided numbness and weakness, so exercises will be modified or avoided when numbness is present to reduce injury risk. Sessions will occur in cool environment to prevent overheating, which can worsen symptoms. For hydrotherapy, water temperature will be checked to ensure safety, and Sarah will be encouraged to stay well hydrated. Due to her increased falls risk, exercises will take place on even surfaces with handrails or stable supports. Her single point stick will remain nearby, especially during fatigue or flare ups, and her Ventolin will be accessible in case of asthma symptoms. A fatigue diary and the Borg RPE scale will be used to monitor energy levels and guide intensity. Her history of a right ankle fracture will also be considered by emphasizing ankle stability, proper footwear, and controlled movements. To adapt the standing button tapping game for Jeffrey, who has had a stroke, it will be modified into a full body seated exercise. Buttons will be placed in front of him and he will tap them with the corresponding hand, example left button, left hand, while marching his feet. Due to muscle imbalances and asymmetry, the seated position reduces falls risk, and I will stand nearby in case he overreaches. This exercise supports all of Jeffrey's goals of reaching with his affected side, promotes strength and neuromuscular connection. Marching builds leg strength and endurance to improve gait and walking ability. Overall, these benefits will enhance his confidence, cardiovascular fitness, and ability to play with his grandchildren. To modify the standing button tapping game for Kenzie, who has cerebral palsy, I would spread the buttons around the room. Using her 2 point support, Kenzie has to walk around the room to tap the buttons. Given Kenzie's forward trunk flexion, kyphosis, and knee valgus, this activity will help reinforce proper gait by encouraging upright posture and weight shifting while walking. To ensure proper use of her posterior chain and upper back, the buttons will occasionally be positioned slightly above shoulder level to activate the scapular stabilizers and postural muscles. The walking directly correlates with her goals to increase walking endurance, speed, and balance to eventually walk with a single point aid. In terms of safety, I would always be by her side as she is a falls risk and make sure to have a chair close by if she needs a break. I'd also make this activity as fun and like a game as possible by providing positive reinforcement to overcome her shyness. To modify the standing button tapping game for Tony, who has a spinal cord injury, he will use a recumbent bite with functional electrical stimulation on his legs while tapping buttons placed in front of him. This dual task experience keeps sessions engaging and cognitively stimulating while training endurance and coordination. It supports Tony's goals of maintaining and improving lower limb strength. Buttons at varying heights will enhance shoulder mobility and end range strength, aiding his goal of playing wheelchair AFL by improving reaction time, game awareness, and promoting neuroplasticity. Safety measures include assisting with bike transfers and monitoring RPE to manage fatigue and prevent autonomic dysreflexia. To modify the wall push-up for Jeffrey, I would place him on a chest press machine with hand ramps. The chest press machine will help Jeffrey improve his left arm function to help achieve his goal of cutting food. Furthermore, this exercise will help to reinforce scapular retraction, core engagement, and symmetry, specifically the pectorals, anterior deltoids, and triceps. By performing this, it promotes bilateral neural activation, supporting motor relearning. In terms of safety, performing this on a machine allows for more controlled movement, adjustable resistance, and greater stabilization. The utilization of hand wraps to aid in gripping the handles will also be used. To modify the wall push-up for Kenzie, I would perform chest passing with a ball and turn it into a game to see how many passes she could do. The chest pass exercise will help increase her upper back and posterior chain exercises, specifically her scapular retractors, posterior deltoids, trapezius, and all of which are essential for achieving her goal of improving her standing posture and alignment. In terms of safety, due to her spasticity, posture, and risk of falls, the ball will be very light in weight, and she will be seated to begin with. As she progresses, these exercises can be progressed into including a heavier ball or to her standing. To modify the wall push-up for Tony, I would place him in a chair with minimal backrest, place a resistance band behind him, and get him to push it forward in front of him. This would be performed at both a bilateral and single arm exercise. By incorporating this, it is strengthening his main muscle groups required for pushing his wheelchair. This directly correlates to his goals. As many wheelchair users suffer from overuse injuries, building foundational strength in his chest, arms, shoulders, and upper back will greatly reduce this. Furthermore, this exercise also promotes the use of his core to work on postural control. This greater motor unit recruitment will improve coordination and endurance. In regard to safety, performing these with a light resistance band to begin with will account for his spasticity and aid in reducing muscle imbalances. Frequent breaks will be used to account for his fatigue levels. The exercise can also be easily be performed from his wheelchair. Thank you for listening.